All right, I think we'll begin now. My name is Dr. Shah. I'm a plastic surgeon and one of the lecturers for the MEC program. The first lecture will be slightly longer than the second one, but then again, I think the first lecture is entitled Invasive Aesthetic Procedures. The first thing I think, of course, I don't expect all of you to be doing this invasive work. It's mainly credentialed for surgeons, but I think it's a good idea that everyone who embarks in aesthetic field should understand at least a little bit of all the procedures that is done. So although you guys will be mainly concentrating on the non-invasive work, however, you would also be getting patients that may require surgical treatment or surgical correction, and they may come, for example, for eyelid rejuvenation. However, when you see them, maybe resurfacing may not be enough. They may actually warrant surgical intervention, and that's where you have to be able to identify conditions that actually can only be corrected by surgery, and you have to counsel the patients or the clients adequately, and then you either refer them to the plastic surgeon that you're familiar with. This, I think, is an issue. It is an important thing to understand, because whatever treatment we give the patient, it's important for you to be able to convey to the patient the outcome of the procedure that you are doing. The danger is always that whatever you do, the patient's expectation is higher than what you can achieve with whatever you're doing. And once you have that imbalance or that mismatch in expectation of the patient, that's when you can get into trouble. Remember, aesthetics, all patients are essentially normal. They want something that would make them a bit more a bit more beautiful, and their expectation of what beauty is what you have to be able to gauge during your consultation. So I think that's important. Anyway, I think let's proceed. So again, I've said I'm actually a plastic surgeon working in UiTM, and also have a private practice in Prince Court. I think most of you would know or would have heard. I mean, all the five top plastic surgical procedures or invasive aesthetic procedures would be either augmentation, liposuction, rhinoplasty, eyelid work, on and tummy tuck. I think across the board, this would be the top five. Of course, what comes first may vary according to region, but this is generally the top five most common procedures, and most plastic surgeons will be able to do this quite well. Although some, for example, rhinoplasties may be a bit more difficult, eyelid work can be a bit more difficult. However, I think most plastic surgeons or cosmetic surgeons would be doing these procedures regularly. All right. The trend of generally, just not cosmetic surgery lah. I mean, there's a trend for people coming in for aesthetic work is on the increase, and I think that is worldwide. I think this is I think generally known. You can see figures here from 97 until now. In 10-year period, you can see almost a fourfold increase in cosmetic procedures that are done. So you can see the trend is coming up. However, because the demand is now increasing, this is in keeping with the wide gap of middle class that we have now. There are more people who are venturing into it. I mean, I guess it's just the normal dynamics of it, where the demand is there, more people who like to go into it. So that's where I think we have come to a point in this country, especially in this country, where maybe we have to start regulating who can do what. Of course, the regulation was not here about 10 years ago. However, I think for us to be able to ensure that we give adequate treatment and treatment of a certain standard, we have to regulate everybody in aesthetic work. So that's where you come in for those more. Anyway, again, same thing as you can. hold on, I think there's something wrong with the screen. Hey, why the screen ada conteng? Sorry, I think the... Anyway, as you can see again, the screen just shows procedures in worldwide versus Asian. Generally, in this part of the world, you can see that the main emphasis on procedures are mainly towards augmentation work, breast augmentation work, and abdominoplasties with maybe rhinoplasties and liposuction, of course. Okay, the incidence of maybe facelifts in general, and we don't get that much in. I mean, the demand is not that much amongst the Asian population. Okay, yes, it is amongst the Caucasian, the European population. Yes, a facelift is a relatively common procedure. However, I think the good thing about Asians, I think generally we age quite well, and we don't have that major sagging to the face that would require proper full facelift work. So the demand for facelifts amongst the Asians is generally quite low compared to the rest of the world. I think that just again in keeping with the how the Asians look like and how the Asians aged. Okay. But again, across the board, as I said, the top 5 procedures would still be liposuction, abdominoplasties, tummy tucks or abdominoplasties, rhinoplasties, eye work, and fat grafting. Again, you can see again, it shows here that the Asians mainly, we tend to concentrate mainly on the breast and the face. We tend to the less work done over the other parts of the body. Again, because I think Asians are generally slimmer, the frame is generally smaller, so maybe the enhancement that required is mainly localized over the face and the chest. This slide again just shows the popularity of cosmetic work. I mean, again, Asia, I guess Koreans, we have the highest number of cosmetic surgery per population, whereas the number of people undergoing cosmetic work, of course, so far is still the highest in America. I think this trend is changing, I'm quite sure, where I think as this generally, the demand for aesthetic work in general increases when you have a larger middle class. That means when you have people or percentage of the population that has extra income or spending power increases, that's when they start to venture into aesthetics. You can see the moment we have a downturn in an economy, one of the first things to be cut off is because once you do not have extra income to spend, of course, the industries that will suffer would be industries that are not actually, I mean, essential. So I would not say aesthetic or cosmetic work is unfortunately, I don't think it's part of the essential services. That's why, as you can see, a downturn economy, trend comes down. However, when you have a large, robust economy, you have a large middle income society which has extra money to spend, that's when the demand for cosmetic work comes in. Okay, again, this is just illustrating the same thing. I wouldn't waste time. Just a brief outline of most cosmetic work would be done by plastic surgeons in general. And also now, because of the regulation wise, any surgical specialty that would like to do cosmetic work would need to be credentialed. And that credentialing is usually done by the plastic surgical fraternity. We have about 90, I mean, it's quite an old slide. We have about close to 95, 96 plastic surgeons in the country. Again, not many. However, more than half of them are in private practice, which means the difference between public and private plastic surgeons would generally mean that the private plastic surgeons essentially do maybe 80-90% cosmetic work, whereas I mean, myself, I'm in a public work, the percentage of cosmetic work maybe 10% of my total volume that I do. Of course, the main bulk of what we do is still reconstructive work. Okay, again, I won't repeat ourselves. Common procedures done are as follows: eyelids, nose, facelifts, again, not that common in Asian population, breastwork, abdominoplasty, and liposuction. I think before we start on, I think this, is also pertinent to actually any procedure, not only surgical procedures, even the non-invasive work, any procedure that we do, especially in aesthetics. I think we have to understand a few principles. Of course, what is reconstructive work? That's to achieve back to norm, which means, for example, someone who has had malignancy or an accident, they've had injury, they've had so post-injury, we like to bring them back to how they were pre-injury. So you're bringing back someone injured back to normal. So that's reconstructive work. What's aesthetic work? Aesthetic work, now you're taking someone who's essentially normal, taking it to the next level where what they feel or what they perceive to be beautiful. Okay, so that's important to understand, because these people do not need the work done. They are well otherwise anyway. And the thing about this is, for reconstructive work or for any other condition in medicine, you know, the risk usually small. I mean, if you have a small, you may get some minor complications are usually quite well accepted in other fields of medicine. However, in aesthetics, even a minor complication can cause a lot of discomfort and can cause a lot of anxiety for the patient, because remember, they are essentially normal. Even so, anything that would delay healing or delay recovery can be a problem for these patients. Okay, so that's what we have to take this into account, and we have to counsel the patients very well before we do any procedures on them. Okay, again, same thing, basically, what is reconstructive and what is aesthetics. Okay, so before, again, the concept of beauty is very important. Any procedure that we do, when we sit and we counsel during our consultation with the patient, is very, very important for us to be able to gauge what these patients want and their expected outcome. The difficulty always occurs where we feel or we perceive or we assume what the patient's final outcome would be. So that's dangerous, especially once the balance between what we can give or what we can deliver and the patient's expectations are not in tally. So consultation is very important for you to be able to gauge that. If you feel you're not able to provide what this patient wants, it's best that you do not touch this patient. Or you tell this patient, look here, what you're asking, you're telling what you're expecting is not feasible, or it's not what we can provide. The patient should understand that, and it's important for you to convey this to the patient. All right. So once the patient understands, then good, then you can proceed. And usually, even though because I mean, complications can occur. All right. This, they have to understand that complications can occur, and if it were to occur, it may warrant prolonged recovery time, prolonged downtime, and may require, either further treatment or regular follow-ups with you. Okay. Again, this photo just shows what beauty is in different centers in different parts of the world. So I know this is extreme examples, but you have to understand that again, beauty tends to change with time. What's considered beautiful tends to change with time, and I guess we have to keep abreast with what is considered beautiful at that particular time. You can see, ancient Egyptians, you can see, the slender shoulder, high waistline, symmetrical face. Then during ancient Greece, slightly plumber, Then you go back to the slim waistline again, Han Dynasty, and then you get someone who's considered beautiful now. So it changes, with time, and we have to tend to keep abreast with what's considered beautiful. Again, this shows again what's a body image. Someone who's a bit more heavy was considered beautiful before, whereas now things are opposite. So again, I think this may change, and I assume definitely will change. Usually beauty is a cycle like fashion. There's a for 30, 40, 50-year cycle, and I guess this would change later on. So the idea is to see who to treat and which patients are, I won't say safe to treat, but it's which patients that you should have in your practice. So you do not want to take on a patient that can give you a lot of problems later on. Okay, so identifying this patient early is important. The moment you operate on them or you do a procedure on them, look here, they're your patients. Whatever happens, they're yours. So that's the problem. Okay, so it's better you do not get involved in the first place. So we have to try and identify this. Again, there are certain warning signs. By no means this is 100% effective. You would still see people slipping through the net, but at least if we have a rough idea, you'll be able to see these people and try to keep them as far from practice as possible. You know, we have to. I mean, the caveat, we call it a caveat for the surgeons, Simon and Sylvia. I mean, okay, Simon, someone who's single, immature, male, over-expected, and narcissistic. This is just what we feel. These are considered high-risk patients. Means these patients will cause problems. No matter how well you do, the procedure that you do, they'll always have some issues with it, and they'll just come and bug you. Okay, so that is a problem. So try and identify these people. If you feel, again, the most important thing you should be able, I think it's your gut feelings plays a big play in here, where you have to identify the moment you feel something is not right during consultation. I mean, it's more than likely, you just try and stay away and be more careful with this patient. Okay, someone who's secure, young, listens. You can see intelligent. You see, you get good vibes from this patient. You can see you can gain the trust. Then maybe you should consider this a good patient, a good candidate. Essentially, you have to gain the trust of the patient. Once they gain your trust, then I think you are sorted, and they understand that even a complication occurs, right? You are able to deal with the complication. I think that's the most important. I mean, this is quite if you do not elicit a smile from a patient, don't operate. So essentially, it's instinct, and this has been published, So again, you should always try and get that rapport with the patient. And the moment you feel you do not have that rapport, the best thing to do, I think you should not operate. Or what you do is, what I do is, I do not operate. If someone comes in during my first consultation, I tend not to operate right away. Okay, if they come for example, liposuction work. Okay, during the first consultation, you assess them, and if you determine yes, liposuction is the procedure that is suitable for them, then you go through the risk, you go through the complications of liposuction, and you go through the procedure with them. And then you get them, look here, you go back, you think about it. If you have any questions, you come back to me again, and then if they come back, they have the questions, then you have started to gain the rapport, then you can start proceeding with them. Okay, that's a recommendation. Of course, a lot of times if someone comes into you, for example, for laser work, or if you say, okay, go home, think about it, come back, you may lose them. No doubt that can happen. And in fact, more than likely, if these patients will go, I think only 1/3 will come back to you. Okay, but the 1/3 that comes back to you, actually, these are people who actually you have gained their trust, and if they will stick with you if you do a good job, And that, I think, that's the most important. You do not want clients or patients who cause problems, and you can get these people where they bug you constantly, and you have a lot of issues after. So it's better you just try and sieve them early. There's a condition called BDD, or body dysmorphic disorder. These are patients that they have issues with how they look like. Okay, it is a psychiatric condition, and unfortunately, a lot of people who come, we as plastic surgeons, as aesthetic doctors, we tend to see them regularly in our clinic because they come for something done, and if it's not identified, they actually get the procedure that they want, and they're never satisfied. Okay, so they always have some issues with it, and they just keep on coming and causing issues. Of course, yes, if they were to come, they spend money. Yeah, you may look at it as a good side, but the thing is, you will not be able to satisfy their expectations. Okay. If you look at the figures, it's quite alarming. Up to more than half, close to half of patients with BDD actually receive the procedure that they want. Now, it is quite alarming, which means we are not. Our role here, we tend to be the gatekeepers for this procedure, because a lot of them come to us, so aesthetic. They want aesthetic work done, and they actually get it done. So it means we are not playing our part right here. If more than up to half, if nearly half of people are actually getting the procedures that they want. Okay. But however, I mean, in a way, the reason why we're missing it because spectrum can be quite varied. It's a huge spectrum. Some people may just have a small percentage of it, which I think maybe a lot of people have some element of this, but it's not causing self-harm and they tend to get over it. Or the other spectrum is that this in associated with other psychiatric conditions where they come in obviously either depressed or uh, and you suspect that something is not right. So if you suspect something is not right, again, maybe it's a good idea for you to just suggest, and then one, don't do the procedure and refer to your psychiatric colleague. Although the moment you tell the patient to go and see a psychiatrist, that may not favor you well with them. But I think identifying these patients are important. I think we have, as doctor, patients will come to you asking a lot of things. And I think it's important for you to be able to counsel the patient, especially during a consultation, on what is considered normal. If they come in, look here, they want to look like something that is, I mean, in your mind, not normal, I think you should tell them, and in fairness, you should not do it. Okay, I think everyone knows about this patient. I mean, she wants to look essentially like a cat or like a tiger or lion, right? So she comes in, but the thing is, she has got that procedure done by the plastic surgeon or the cosmetic surgeon. So is this? I think there's certain ethical issues that we have to maintain, the standards we have to maintain, and I think we should not just because they're paying you doesn't mean you have to do it. Okay, so that I think standards have to be maintained. I think it's important that we remember we are doctors first. And that's the most important. We have to differentiate ourselves from the beauticians outside, and who I think won't mind doing anything if they're paid for. So standards have to be maintained. I think that's important. I'll not go into the common aesthetic procedures, just a brief outline of what it is. I won't go into detail because I think it's beyond the scope of this. Again, I don't expect you to do it. I think I just expect you to be able to understand what the procedure involves, and maybe for you to identify conditions that actually need surgical correction as opposed to a non-invasive work. Eyelids, I think one of the more common procedures done. The thing about Malaysia is that we live in a relatively multi-ethnic, we are a multi-ethnic group of people, all of us living in one country, hopefully harmoniously. We are a bit different from maybe our colleagues who are in maybe Taiwan, Japan, Korea, where they tend to be limited to one particular ethnic composition. So what's considered beautiful there, generally it's the same standard of beauty and same style correction that needs to be done. However, Malaysia, I think we have, because of this variety in ethnical conditions, the correction for like Malay and Indian eyelid or Caucasian eyelid is a bit different compared to a Oriental eyelid. I think that's important. And also for you to be able to identify it and understand the anatomical differences between this group or groups and what needs to be corrected. I think that's important. Okay. So blepharoplasties in general, there are two indications for it. One is aesthetics. Of course, you want to rejuvenate. You want to the upper third of the face, and of course, it's also functional, where you see, because as you grow old, you get this droopiness and you get increased laxity of the upper eyelid skin and increased protrusion of the fat. So this can cause a tired look, it can cause and also drooping of the skin. So so a lot of these patients, they want some correction done. So I mean, again, indications are there. So you just have to identify them, so upper eyelid can just have maybe excess skin alone, or the oriental eyelid where you have the absence of the lid crease. So now in the oriental eyelid, essentially you're trying to recreate the fold, okay? Because the fold generally is not there, or if it is there, it's very shallow and it's very low in the lid. Okay, so you want to increase form the fold, and it's a common procedure done. And and the thing about it is, it's not the easiest procedure. Okay, when you're dealing with right and left, you have to be able to gain symmetry, and that's where consistency comes in your work, consistency in your skill, in your procedure, in the outcome of your procedure comes in. Okay. You also have lower eyelid blepharoplasty. That's lower eyelid work. That's where you have eye bags. Most patients come in, look here, eye bag, I have eye bags. Okay, that's essentially lower eyelid work. So I won't go into detail here, but the thing is, whenever you see there's complex anatomy, especially over the face and the neck. Reason being is because there's a lot of things going on in such a small enclosed area, and you have to be able to understand anatomy very, very, very well if you are to do a procedure in that area. And understanding anatomy takes time and it takes experience. Okay, so these two things. So you have to understand, and before you do any treatment, especially when you deal with injectables, when you do fillers, when you inject Botox, you have to understand exactly where you're injecting. Okay, and that's the most important thing. Okay, so and there are various things that you do to try and prevent complications, and that's what you have to do. You have to understand it. Okay, I won't go into detail. I think it's a bit. So, the as I said again, because of the variety of patients that come to you, each patient may need different things done. Okay, so that's where things come in. So for the surgeon to come, it's not one procedure fits all. So this is where the experience of the surgeon comes in, and upper lid work, for example, where you place the incision, to remove the fat or not, to tighten the septum. So all this, it just plays in. The clinical or the surgeon would have to determine all this for each particular patient. Okay, so it's not just the idea I want to show this is just to show that it's not one procedure fits all. Okay, and understanding anatomy is important. All right. Low eyelid is the same. Low eyelid, in fact, is a bit more difficult than upper eyelid because it's less forgiving. If you take too much skin, you get the show, you get the ectropion. So it is those who are new to the work, to this field, would essentially start doing upper eyelid work first before you start venturing to the lower eyelids. Okay. Again, this is show some results. The good thing, if you do it right, you can get the results quite. You can get significant results relatively fast. Okay, this, I mean, even after the first right after right after operation, you can see patients would see the difference already. So the thing is, again, I mean, identifying what to do, I think is important. You have to assess the patients. Again, like most things, pre-op assessments is very important because you have to identify patients that have a higher risk of complications later on, patients who this procedure would not help or may not need the procedure at all. So I think it's important. So like most things, again, pre-op assessment is important, and understanding complications is important. Okay. Again, you can see bruising, it can happen. The thing is, you have to tell the patient that these procedures can happen, these complications can happen, and go through them. And the thing is, consent form is also important. They have to identify, every complication that you explain, you either write it down and the patient signs later on. Again, protecting yourself is important, and also getting the patient to understand what procedure needs to be done. Okay. Rhinoplasties, again, so this is essentially what I call a nose job. It is one of the most challenging work. I think it's not an easy procedure. Again, this is something that I think surgeons only venture into after a while, and once they understand the anatomy. Because important here is, again, understanding anatomy and what is causing the current problem is important, because to correct it can be very difficult. And if you get it wrong, for you to go and do revision work in the nose, it's very, very challenging. Okay. So most people, what they'll do, they'll come in, they say they want, essentially most of them will just want the nose or the bridge to be higher. Okay. Again, in the Asian population, because of the multi-ethnic ethnicity here, the tendency, most people who come for bridge work are essentially mainly the Oriental public, the Oriental nose or eyelid and the nose, where you just want increase in the dorsal bridge. Of course, most people would also may need tip augmentation and together with bridge or nasal bridge augmentation. So identifying the problem is important. You come in, you assess the patient, what the patient needs, what the patient expects, and then you correct it accordingly. So again, there's no one procedure that fits all. Okay, you have to assess everything from the dorsum of the nose, tip of the nose, like ala complex, septum. So because once you're there, you can correct all this in one operation. Okay, and you're able. The most important thing is you have to understand what the patient wants, and you are able to achieve what the expectation of the patient. There are various ways of augmenting the nose. I mean, if you use autologous, you can use your own. A lot of patients now, the tendency here is to come and say, look, I do not want any foreign material. I want to use my own. So that's where, your patient's own rib cartilage, ear cartilage can be used. Of course, the downside is that you get a donor site that needs surgical, you have a donor site or a risk of donor site mobility. Simple way, of course, off-the-shelf silicone implants can just be put in, again, where you do not need a donor site. But of course, there's also a downside for this. The body can reject silicone. And of course, any corrective work, in my opinion, you need autologous work. It means if someone comes in for a corrective procedure for the nose, anything you need, you will not, this patient is not, there's no indication for silicone or foreign material for for corrective surgery, okay, or secondary surgery. There are various ways of how rhinoplasty can be done. I think you have to understand again. So that's where, and again, I have to emphasize it is difficult to do rhinoplasty. It's one of the more challenging procedures that can be done. So you can see, I mean, this patient, although she's a cleft patient, what she needed, she did not need any bridge augmentation. She just need tip augmentation, right? So what was done for her, we just opened her up, we realigned the lower lateral cartilage, and we put a ear cartilage as a strut to raise the tip. And I mean, I think not too bad a result. The idea is the result has to look natural, okay? And I think she's quite happy with it. So you just want some tip augmentation, all right? Opening the nose now, getting exposure is important. This is how we do it. We just make a nick over the tip and the rim of the nose. So this heals quite well actually, and the scar is hidden. So you don't actually, the scar is quite, it's not very obvious, and you tend not to see it, especially at conversation distance, because the scar is mainly located over the lower end of the nose. Okay. This is a patient came in a foreign body reaction. You can see the redness. She had an implant done before. Oh, sorry, she still has an implant in. Multiple revision work also with implant. That's where I think any revision work, implant, there's no role for silicone implant. Okay, any revision work to the nose, you have to use autologous work, autologous material. That's your own cartilage or your or depends dermis or fat. Okay, so what she has here is foreign body reaction from the silicone implant. The only way to treat this is to remove it, all right? Then you have to replace it somehow. So this was removed. You can see I replaced it with a dermal fat for the bridge augmentation, and he's an old, I think nearly 80 or 78-year-old lady who came in with an extruded implant. This can happen especially, and you see what happens is because of the scarring, you get a short nose, right? This is short nose deformity where because of the scarring of the implant, it contracts and it tilts your nose up. Okay, anyway, she just wanted the implant out. There's another one. Someone came in with previous history implant. I think got a blow to the nose and you get a hematoma, peri-implant hematoma. Okay. So we've touched on eyelid, we've touched on rhinoplasties. Now let's touch facelift. Although I say it's not very common, facelifts in this region, but But again, I think it's good to understand special indication. And the essential indications of facelift is that, of course, you want to correct the aging process. All right, where everything usually sags down, but it's not only everything that sags down. It's not just a gravity effect. You see, you also have laxity of certain tendons and movement or displacement of certain fat pads. Okay, so understanding it is also important. So that's where things come in, and essentially facelifts tendencies for the slightly older age group, 40, 50 and above, where you have excess skin. You send, you know, it's not just repositioning the fat pads and tightening, but you also need to address the excess skin. Okay. Again, I always put, again, contraindication. Every procedure has contraindications. Again, for here is of course smokers and someone with a history of maybe bad scarring or keloid formation, because the scar is actually can be quite noticeable if you get a keloid, because the facelift scar is usually hidden around the preauricular area and also into the hairline, front and back. Okay, so if if we have seen, or some patients who are prone to keloids, if you get a keloid over that area, it can be a disaster, you know. Smokers, because tendency the healing process takes prolonged time, and you can get flat necrosis over the area. Again, various methods. Facelift is just one terminology. There are various types of facelifts, and most patients may need one or the other. So again, identifying the type of facelifts that the patient need is important. Of course, this depends again on the surgeon that assess them. Okay, but if it's done properly, I think the results are quite good, and it's usually done together with some sort of neck rejuvenation, right, and upper face rejuvenation. Again, patient of ours again. Okay, we do a lot of markings because we know certain areas that are more prone to higher risk. There are a lot of structures passing through them. So whenever you treat the face, it's always a certain area. We call them danger triangles. So there are various triangles that are considered danger zones. But essentially, because the face is such a small area with a lot of things running through, if you ask me, the whole face should be considered a danger area, right? Not just the triangles that you read about. Okay, so again, have that in mind whenever you do any procedure. Okay, this is just a smash lift that we did. Expectation of patient is important. Okay, you're not doing miracles. We are not miracle workers. So if the patient thinks that he's going to look 30 years younger by the facelift, okay, that's wrong. You know, so that's why again, tell the patient. You must tell the patient. Get the patient during the consultation to understand what the expectations the patients, or you can advise the patient that the patient might have. If the expectations is beyond what you can provide, please do not do it. Okay. There are a lot of things about trade lifts now. The thing is, a trade lift doesn't replace a facelift. Okay, what trades does is it just tries to replace or suspend whatever has come down, and also maybe recorrect positions. Certain threads maybe if you can place it rightly, you can recorrect maybe the fat pads or the position of the fat pads. Okay, and it's important. However, the patients who need facelifts are usually the younger ones. Okay, because you will not be able to correct excess skin or skin laxity with this. You're able to just, so these are patients who are relatively young, 30, late 30s, maybe early 40s, where the aging process, where the face just begins to sag down, that's when you should go in. And those are patients that are indicated for trade lifts. All right. So just remember, the trade lift is not a replacement for facelifts. Okay. Indications are totally different. Like most things, there are complications. All procedures have complications. You have to understand. I think you have to tell this to the patient. I know I'm repeating myself, but this, I think the emphasis of complications can occur has to be told to the patient. I think this is important, because you can't just say, this is just a laser procedure, no problem, it's safe, you can come, have it done and go home, everything be fine. No. Yes, majority of patients that occurs, but you have to understand there are certain percentage of people that complications can occur. So you have to tell that and tell the patient that complications can occur, and it can. And however, if you were to do a procedure, you should be able to deal with the complications. I think that's also important. No, patients will have confidence in you if they know that you can deal. If a complication were to occur, you would be able to deal with it. Brow lifts, not very common again. Extreme. This patient had a stroke, I can say Bell's palsy. So, and because of his forehead, you can see there are various ways of doing brow lifts. One, you can do endoscopic work. You can do it via, again, you can, from mild brow lifts, you can actually play around with the muscles where you can use Botox to try and lift the brow. However, for in this case, he has a large forehead, so endoscopic work will not be able to do much. And we just excise the skin above and just lift the eyebrow. It's not a very common thing to do, but it can just work. I don't do much, so that's the only patient I had actually. Breast surgery. So now we have covered mainly eyelid, blepharoplasties, rhinoplasties, touch a bit on facelifts, and now I think we just a bit on breast surgery. Most common procedures, I do actually reduction somehow. People don't come to me for augmentation work, but they come to me for reduction work. And augmentation and reduction, I think these are two most common procedures for breast, in breast surgery or in breast work for aesthetics. Okay. Augmentation can be, again, most commonly be just putting in an implant, or nowadays, again, patients are beginning to be reluctant to put in any foreign body, of course. Autologous correction can be done where either use fat or flaps can be used to enhance the breast. So it again depends what the patient wants. Of course, if you are using fat grafting, the patient must have enough fat. And the problem is a lot of patients that come for augmentation work are usually quite slim anyway, so they may not have enough fat. So then the options are quite limited. Just get the implant. Okay. Implant work is relatively okay. It's not. It's the most. I think the most difficult procedure, the most difficult decision for you, or the most important decision, in fact, for the surgeon would be to identify what type of implant to put in. The reason being is because, again, that's where expectations of the patient and what you can provide has to match. Okay, patients may look here, want 4, 5, 6 fold, 5 cup folds increase. That may not be possible. Yes, they are large implants, but the patient may not be able to, the skin envelope may not be able to hold the implant. So that's where you have to tell the patient. Okay. Of course, there are various ways of implant. There are various types of implants. I won't go into it. There are the round implants, anatomical implants. You have these textured implants, smooth implants. Yeah, that's beyond the scope of this. Essentially, silicone is relatively safe, has been proven to be safe now, although there's a risk of certain type of lymphoma, if you have heard, least readily associated with a type of silicone implant. All right. It mainly seems to be associated with not only one particular brand, but the textured implants. So there we have to see. Putting implant again, I can just sizing the implant and placing it in. You have to just determine the not only the type of implant, the size of implant, but also where you're going to place the implant. So that's again what the surgeon has to come in and you deal with the patient. Indications essentially just to make the breast bigger. Okay. But the most important is you have to tell the patient there are limitations to the size of implant that can go in because the skin envelope of everyone varies. How long does the implant last? I think a lot of people ask this. The newer generation implants, if you ask the companies, they say it's a lifetime. However, I think we tell the patients in most implants, lifespan is 10 years. After that, you may need to have the implant removed. The reason being is because the longer you have the implant in, the higher chance of you getting what we call a capsular contracture. Okay, where because I think the foreign body, the silicone, I think triggers a foreign body reaction. Maybe it causes a capsule. There are various theories of why this is happening. So the capsule acts as a scar and tends to contract, and you may get some sort of capsular contracture. With the newer implant, supposedly, of course, the risk of capsular contracture supposedly comes down. That's why they tend to say now it's a lifelong, implants can go in lifelong. But we tend to tell the patient, look here, it just lasts for 10 years. After that, you may need the implant to be removed. Okay. And they also, as I said earlier on, other types of methods of augmentation, fat grafting and flaps are definitely one of them. But again, it determines on the suitability of the patient. Placement of the implant is also important. You just put below subglandular, that's below the breast tissue, submuscular below the pectoralis muscle. Then you have dual plane where part of it is under the muscle, part of it is under the breast. Again, placement, this will determine again what the patient wants. It's more a natural look if you put it under muscle or dual plane, but sometimes the patient, they want this upper fullness where they want the, so with this you may need to put an implant maybe subglandularly. But again, this just determines when you consult a patient, you see what the patient wants, and then that determines where you place the implant. Of course, not only what the patient wants, but of course you assess the patient's torso and you see if it's suitable for you to place the implant subglandularly or you need to go in submuscular. Okay.
Tahu semua? Apa tahu semua?
Cium-cium.
Ada. Jangan.
Often see. So again, incisions is another thing. I mean, most surgeons will put in either, currently I think most surgeons will go in via inframammary incision. The reason being is because you want control. The most important thing when you put in you place an implant in this, you want to have full control where you put in the implant. Okay, you may not get control if you put it in transaxillarily, because I think one, you see the distance, and secondly it's very difficult to create that plane. And if you were to get, hematoma complication, you still have to go in inframammary anyway. So I think most surgeons, I think across the board, I think we say look here inframammary incision. Of course, there are other ways of going in which may be less common. Everything has complications, I said earlier. So just that, now the risk of ALCL, that's a type of lymphoma, is 1 to 1 in 10,000. So I think recently Malaysia has got our first patient with it. Right. So it is a malignancy that has been associated with silicone implants. So although not very common, but it's definitely, there is now a malignancy linked to it. So you have to tell this to the patient. Okay. I mentioned capsular contracture. This is what you get, where you see the implant. What patients complain of usually complain of sudden pain and distortion of the breast. So the only way of doing it is you have to remove the implant. There's some photos of it. I mean, anyway, reduction is another one. In fact, this is one of the most, I would say, satisfying surgery to do, because the patient feels almost instant relief when you do a reduction. A lot of patients that come in, usually they come in with when they eventually show up and see you, they've been living with it for quite a while. You have this shoulder pains, lower back pains. They have problems fitting garments. They can't get a bra. They can't do exercise because of the garments are not suitable. They can't get it properly fitted. So it affects them quite a lot, quite significantly affects them. And when you come in, once you do a procedure, you can see there's almost instant relief they have. So it's one of, I think, the more gratifying procedures for you to do, especially for the patient. Again, anyway, this is just to hopefully to keep everyone awake. All right. Like most procedures, again, there's a thought process that goes through. Each patient may not, and there's no one procedure that fits all. I think this, again, is more common. So that's where experience of the surgeon comes in. So what should we do for each patient? Although all this, like liposuction, abdominoplasties, facelifts, rhinoplasties, breast reduction, they all comes under one category. However, for every procedure, for every one big heading, there's a lot of subtypes, and which particular procedure or subtype that needs to be done, that's where the surgeon comes in, and the experience of the surgeons comes in. So I think it's not something that to be taken lightly. There are a lot of people feel, breast is just putting the implant. Anyone can do it. Yes, anyone can do it. But the moment something occurs, if you do it wrong, now dealing with the sequelae, now that takes experience. Okay, so you should only be able to do a procedure if you are able to sort out the complication. This is a few procedures, a few patients that we have. I mean, anyway, the breast lift, we have touched reduction. Now we're going to lift. Like the same concept as reduction. Essentially, just trying to lift the nipple complex up, and because as you age, remember you lose volume. So when you lose volume, it's like a balloon, right? You remove the air. What happens to the balloon? It just flops down. So when we lift the concepts, either we put in air a bit more, bring everything up, or we lift the breast. Okay, so that's where the breast lift comes in. So the same concept as technicality, same principle applies with a reduction, where essentially you're just lifting the nipple areolar complex. But with reduction, we're also removing breast tissue. With breast lift, we are just lifting up or volumizing the breast. So various types, of course, various classifications of ptosis. So I mean, with each different, it may require different procedures. All right. So again, I won't go into detail. I think abdominoplasty, again, a common procedure done, is essentially what we call a tummy tuck. Very popular here, especially in Malaysia, quite a common procedure. The thing difference, a lot of people say, what's the difference between tummy tuck and liposuction? I think the main difference here would be liposuction removes fat. If you have just pure increased fat alone yes, liposuction can be removed. However, a lot of people, they don't have not only increased fat, you have increased excess skin laxity. All right. So liposuction can only remove fat. So remember, if you just remove the fat, it's again like a balloon, you remove the air, everything sags down. Right? So abdominoplasty also addresses the skin. Where you're not only removing fat, you're also removing the skin, so that removing the excess skin, so that for you to get the in the outcome that you want. So remember, liposuction just fat removal. If you feel that the patient has excess skin, then you're talking about abdominoplasty. Okay. Again, selecting the patient is important. I mean, what we feel that the weight loss, a lot of patients come in, they say they're trying to lose weight anyway. So we tend to allow them to lose weight first. Once the weight plateaus, only then we go in and do the abdominoplasty, because we don't want a yo-yo weight, because remember, after the surgery it can rebound. They may need, they can, it can recur. The fat can hypertrophy again, and you may need further surgery again. So usually what we tell the patient, make sure your weight is plateaued, correct your lifestyle changes first before you come for surgery. All right. So abdominal wall laxity, excess skin, right? Striae, of course, that's because you're removing the skin, so you can sort it out. And if you have recti, diastasis of the recti, it can be corrected during your abdominoplasty. So identifying this is important. So that's where the initial consultation, that's what the surgeon will do, to see you assess the torso again and to see what needs to be done. This is where we just use a mesh just to strengthen the abdominal wall. But anyway, remember, the patient would have a scar, okay? But you try to hide the scar in the crease or in the fold or the lower abdominal fold. Complications can occur, most things again, so again, that's very important to tell the patient complications can occur. Liposuction, another very common procedure done, essentially just removing fat. Of course, it has to be done correctly. All right. It can be a dangerous procedure, so it should be done by someone who's trained to do it. Even then, complications can still occur. We're not saying complications can't occur, but at least you try to limit the complications and or reduce the risk of complications. So I mean, it is important. So the procedure is that you remove fat. Okay, there are various techniques that you use, various machines that you use, but essentially you're just putting in a cannula and you suck off the fat. Okay. So there are two ways. One, of course, the fat is physically removed, and you would get improvement usually after three to 4 months. The reason being is because once you put the fat, is very sensitive. So you're putting in a trocar to remove, right? You also get damage to fat cells. So those fat cells will also be absorbed after a while. So you tell the patient the final results usually about 3 to 4, maybe up to 6 months. Then you get a final result, how it's going to be. All right. But again, it's something that is done properly. The outcome, the patient is quite satisfied because they see the outcome almost right away. Right? Various indications for it. Again, a lot of it, the best indication for liposuction is localized fat. your hips, your abdomen, where this resistant fat that just don't want, or stubborn fat we call it, do not want to go away, right? So small volume areas, in fact, liposuction is very, very is suitable and very effective. Okay, it can also be done in gynecomastia, where especially the earlier type, the early types of gynecomastia, the maybe 1 and 2A, where you don't have excess skin yet, can also I think liposuction is also suitable. Okay. Again, identifying it, because we do this, I know it's like a contours just to see where the fat is located for us to mark before we go in and do the procedure. Okay, 1 of ours. Again, localized fat is, I think, liposuction place is very effective. Localized and resistant fat. Okay. Okay, complications can occur: bruising, necrosis, infection. And again, we spend a lot of time when we counsel a patient regarding complications for aesthetic work. It's not to frighten them. It's just that you have to understand there is a risk for whatever they do. So going through it is important, and tell them. I now, for liposuction, especially bruising, I say it's a sequelae as opposed to complication. You definitely get it. I just tell them. The reason being is because you're going through, essentially you're going through blind. You're putting a trocar into the fat blindly. More than likely you hit a few vessels. So you would get bruising. So I tell the patient, it's no more complications. It's a sequelae of a procedure. If you get it, if you don't get it, you might get it. If you get it, it takes about 3 to 4 weeks to disappear, so that they understand. Okay. I mean, it's my last few slides. You tend to get certain things. This is a patient came in, HIV patient on treatment, heart treatment. I think this is one of very complication for heart or for treatment for HIV is actually hyper or hypodystrophy of fat. They usually get hyperdystrophy humps. They get hypotrophy of fat over the face. In fact, she had hypertrophy of fat over her labia majora. Okay, one of the common, not common, it's one of the very rare side effects for heart treatment. And I think this is only the second case published. I think we happen to publish the second case that's in the literature. So we describe our treatment method and what we did for the patient. And I think you can get this published. It is published. You can get it online. Anyway, summary. I think for all aesthetic work, patient selection is important. Communicate the patient. Gain the trust for the patient. Please understand anatomy if you're doing any procedures, because understanding anatomy is I think, utmost important before you do any procedure. This to reduce the risk and complications further on. Proper technique, get proper training. This is not something for you to play around with. Let's just start and do. No, please get proper training first before you do it. And if it's performed well, it can be very rewarding. Anyway, thank you very much.